Wonderful. Thank you so much, Dana. My name is Marjan Farid. I'm the director of the Cornea, Cataract, and Refractive Surgery Division here at the Gavin Herbert Eye Institute at UC Irvine. It's a pleasure being here with you all tonight. And our topic tonight is on dry eye disease. And specifically, I'm going to give some updates on what we have, how we diagnose dry eye disease, what does it mean, and then what's in the pipeline. There's a few interesting things coming down the pike in terms of treatments. So, and please feel free to put questions in the chat. I'll try to address those as we go along. I'll try to direct my attention there, but we'll also have some Q&A time at the end. So, I have a lot of patients with dry eye disease, and I see some familiar names out here in our audience today. And, when patients ask me what gave me dry eye disease, why do I have dry eye disease? What is that from? It's really hard to put one thing to it because it's such a multifactorial disease. And in Southern California, we're much more susceptible because we live in very arid conditions. There's other things, visual tasking, our screen time increase with cell phones and computers. That has been a big player in why we're seeing so much more dry eye disease. Systemic medications, lifestyle, pollutants, all of these impact our risk of dry eye disease. What triggers it? Again, multifactorial. They can be medications that we take for other things like blood pressure medications or anti-allergy medications that will make our dry eye worse or make our tear film dysfunction worse. Any history of surgery, if you've had cataract surgery, if you've had LASIK surgery, or any surgery on the eyes go through a period where they do get drier for a period. Usually that's temporary. And with correct treatment, we can usually bounce back from that dry eyes, but the surgery itself can be a trigger. Systemic autoimmune diseases, these can cause really the worst dry eye disease we see. So patients who have rheumatoid arthritis, lupus, or any of these other autoimmune thyroid disease, for example, even diabetes, they can really cause tear film dysfunction that's pretty severe. And then the big one is hormonal shifts. And this is why women tend to be a little bit more susceptible. Testosterone is somewhat protective. So women tend to suffer more from dry eye disease than men, but that's not exclusive. I have plenty of men who have dry eye problems as well. And then oil gland dysfunction, and we'll talk about that. But wherever it starts, wherever the trigger is, the downstream effects, the symptoms, and some of the signs are all very similar. So again, predisposing factors: age, female gender, underlying oil gland dysfunction. So the meibomian glands are the oil glands that produce the oils in our tear film. Medications we talked about, history of surgery. Contact lens wear is another big one. Patients with contact lens who wear contact lenses chronically often don't know they have dry eyes because every day they're putting a contact lens, which is acting like a Band-Aid on the surface of their eye. So that almost masks some of the symptoms. But a contact lens wearer who's worn contact lenses for years and then has either LASIK or cataract surgery or something, and now they don't need their contact lenses anymore, they do feel more dry. And then autoimmune diseases, as we talked about. So the symptoms are so variable as well, from mild to severe to very, very severe. Some patients will describe itchy, sandy, gritty, dry eye feeling. Some patients don't have those pain sensations at all and don't realize they have dry eye disease. What they have is fluctuating vision. Nothing else causes fluctuating vision other than tear film dysfunction. So if you have vision that's up and down, some days better, some days worse, it improves with blinking. Some patients say they start out reading and they start out okay, but then they get blurry. Is it my cataract? No, it's not your cataract. That's tear film dysfunction. So that's a form of dry eyes. And then use of artificial tears increases as patients feel more dry. How do we diagnose these? How do we diagnose dry eye disease? Well, there's actually a lot of fancy diagnostic tests now as well. I'll go over some of those. But some of the basic things are staining the tear film, looking at the areas of the tear film that break up very rapidly. So we use some of these tests in the clinic to assess the degree of severity and ocular surface involvement. Most common symptoms, again, are from poor lubrication from the tear film. Burning, sore, gritty pain, ocular fatigue, fluctuating vision, that's from altered optical clarity. So if you think of the tear film, it's really an organ. It's the first organ or the first refractive surface that the light hits when it enters the eye. Before it hits the cornea, before it hits the lens, it hits the tear film. So if the tear film is irregular, then you're going to get irregular vision. And, the tear film is a very complex organ because it not only has an oil layer, it has a water layer, an aqueous layer, we call it, with 3,000 proteins in there. So it's not just water. And this is why artificial tears don't really supply all of the nutrition that your natural tears have. And then there's a mucus layer that makes it all stick to the surface of the eye. But light sensitivity can be a symptom. And then obviously these things can impact our daily work, whether it's reading, computer work, watching TV, and our blink rate goes down with those activities. So that makes things worse. So again, tear breakup time, sometimes we'll use a little fluorescein dye in the tears, and we'll use a blue light to and assess how smooth that fluorescein dye stays on the ocular surface. If it breaks up quickly, we call that a rapid tear breakup time, which is really indicative of a poor oil layer in the tear film. So where are the oils made? Well, they're made in the eyelids, in meibomian glands. And the meibomian glands live along the upper and lower eyelids. And over time, they can, the oils can turn into fats, as you see here in these pictures. They can have a lot of inflammation associated with them. So you see in this first picture where the lid margin is very red, we see a lot of blood vessels. That's an inflamed meibomian gland disease. And patients who have ocular rosacea or rosacea of the skin around their face will see this very commonly around the oil glands of their lids. This causes inflammation in the tear film. It causes the oil glands to be very acidic. In the second picture, you don't see as much of the inflammation, but you can see the turbid secretions. So the oils, where those oils should be like an olive oil consistent lipid that's released from the tear film, now it's turned into like toothpaste. And so that's not going to lubricate the surface of the tear film. That's going to be a very poor quality oil, and it often doesn't even release because it's clogged up in those oil glands. Here's a picture of or a video of an expression of those oil glands, and you can see sometimes you can't see them on the surface, but we can assess they're trapped, and you can see when we squeeze them, all of that toothpaste-like secretion. This is very abnormal. This is not the way the oils need to look. They should look like olive oil. So that's a very dramatic video showing a patient with severe turbid secretions, and it's in both eyes. So we go over to the other eye of this patient, and you can see the same type of disorder. You could, on the surface, you wouldn't be able to tell that there's anything wrong with these lids, but this patient will get very severe dry eyes. So what do we do? Well, meibomian gland disease is the most common part of dry eye disease. About 85% of patients with dry eye disease have a component of lid gland dysfunction. And it really is thought to be one of the leading causes of dry eye disease throughout the world. So, I always talk to my patients about doing hot compresses to keep those oil glands flowing. And there's a reason the oils are really essential to a well-seeing eye and a well-feeling eye. And often that's the main problem. Again, 85% of dry eye disease is what we call evaporative dry eyes from oil gland dysfunction. These are some of the other dyes we use to stain the ocular surface. So fluorescein is that top picture you see. Sometimes we use something called rose bengal, which is a pink stain, or a lissamine green, which is a very green stain. And these also look for areas where the surface epithelial cells of the eye, the cornea, and the conjunctiva are degenerating. And you can see that they're unhealthy. And so we pick up very early disease using these dyes. There's some point of care tests that we can do in the office as well. And again, we start to do these a little bit earlier. So many patients with dry eye disease will not have the pain sensation. So for example, the study looked at 50% of cataract surgery patients, so older patients who come in for cataracts, they actually 40% are asymptomatic, meaning they have no sensation of dry eye disease. But when we look at them, more than 50% of those patients actually have signs of dry eye disease when we delve further. So we don't necessarily wait to hear the pain symptoms from patients to start testing. And a lot of patients will say, well, I never knew I had dry eyes. So we look for that before surgery. Sometimes it's missed, and patients will feel more dry after cataract surgery and say, well, the cataract surgery made me drier. Well, that's true, but you were probably dry to begin with, and it was not really addressed. And now it's just gotten worse. So really looking for it before cataract surgery is really essential. We can test the osmolarity of the tear film using this little machine. It gives us a number, a little bit of a quantitative analysis of how dry the tears are. This is another, it's called Inflammadry, another test we can do in the office that looks for inflammation in the tear film specifically. So when the tears have been off balance for a long enough time, they actually become inflamed. It triggers a cycle of inflammation. And so this particular test, it's almost like a pregnancy test, will give us a pink sign if there's those inflammatory markers in the tear film. So it helps guide our decision on how to treat. We are able to take pictures of the oil layer. We're able to take pictures of the oil glands, the meibomian glands. You can see a healthy oil meibomian gland sort of row on the lower lid in that first picture. You can see some dropout of oil glands in that middle picture. And you can see in that last picture, that patient, half of, or more than half of their oil glands are completely atrophied over time. We'll see that with age, and we'll see that in patients who have chronic oil, like that toothpaste, the toothpastey secretions over time. If you don't express them, if you don't normalize them, those glands will die. And so then we get a picture like that last picture. And those patients suffer the most severe form of dry eye disease. So again, the question is it the water layer? Is it the oil layer? It doesn't really matter. Both of these things often overlap and lead to inflammation in the tear film. Treatments. Oh my gosh, there's so many treatment strategies available. If there was one thing that could cure all dry eye disease, my job would be so much easier. But unfortunately, there isn't. There's no magic cure. And what I try to do is find the right cocktail for patients based on their compilation of symptoms, how much is their oil glands involved, how much inflammation is in their tear film, and we try to tailor a custom treatment specific for the patient that I have in front of me. As you can see, there's a lot of treatments available now, and there's more coming. There's more in front of the FDA. I'll try to talk about some of those as we go along. Artificial tears are wonderful and, a first-line agent for mild cases, but often they're not enough. They don't really treat the underlying disease, but they're very good. They're palliative. Often in the early phase of dry eyes, patients feel like they put artificial tears in a few times a day, and that really does the trick. I usually recommend non-preserved. And there's some artificial tears that have an oil base that tends to be a little bit more lubricating and sits on the ocular surface a little bit better. There's gels and ointments that can be used at bedtime, especially if the lids don't close well. When you're sleeping, those gels are really good for patients who have some of that at nighttime. So this is a great first-line therapy. I have a lot of patients ask me, well, which artificial tear is better than the others? I have a list of the ones I like, non-preserved, but often I tell patients, find what works for you and what feels good on your eyes, because every patient is a little bit different. Anti-inflammatories. So there's a lot of different anti-inflammatory options. These are prescription eye drops for dry eye disease. Steroids are wonderful and terrible. They're wonderful because they cool down inflammation very, very quickly. And in patients that have a lot of tear film inflammation, they feel very good quickly with steroid drops. But they're not a great long-term solution. And this is because steroids can have a lot of side effects, including elevating the intraocular pressure, which is one of the bigger risk factors. There are now really good low potency, mild steroids that have a low side effect profile. So for patients that I trust, I'll often prescribe a low dose steroid, a milder. There's actually one that's on label now, FDA approved for use in dry eye disease and specifically for flare-ups in dry eye disease. That's been shown to be very, very safe. So I'll tell the patient, go ahead and use this for 2 weeks. Keep it in your medicine cabinet. It's your rescue. Use it when you need for 1 to 2 weeks at a time when you have a flare-up. Because dry eye disease, we know it's not a flat line. It's as my partner calls it, it's a roller coaster. Some days it's worse, and sometimes it's better. And there's usually triggers that make it worse. Maybe you take a flight and you're in sort of an air-conditioned area, and that can trigger a flare. Or you read for a little bit too long one night, and that can trigger a flare. So flare-ups are very, very common in dry eye disease, and steroids are great for flare-ups, specifically these lower potency steroids. This is not a CME talk, so I like Isubis, Lotamax or Lotaprednol. These are all very low potency, safe steroids, again, for short term. Then we have our long-term anti-inflammatories that are safe. They don't have side effects in the long term. They're not addicting. They don't cause pressure rise. And these are drops that we can keep patients on in the long term. They don't work as fast. So often they take 2 to 4 to 6 weeks to even kick in. And a lot of you may already be on this. Restasis was the first prescription drop approved for dry eye disease like 15 years ago. It's the one we've had around the longest. But sometimes insurance covers one and not the other. So we kind of search and see which one gets covered better based on different payer models and different insurances. Xiidra is a little bit newer. It hits the inflammatory pathway a little bit better than Restasis alone. But sometimes patients don't like how it feels on the eye. So I have patients that love Xiidra and hate Restasis. I have patients that love Restasis and hate Xiidra. So we try to figure out what the patient likes on their eye, because sometimes these burn, sometimes they sting, sometimes they can blur the vision for a few minutes. And Cequa is probably the newest one. It's the same active ingredient as Restasis, but the delivery vehicle is a little bit better, so it stays on the eye and penetrates a little bit better. So this is another exciting pathway in treatment of dry eye disease. And we have a nerve that ends at the inner tip of our nose. And when you trigger that nerve, this is the trigeminal nerve, it sends a message to the lacrimal functional unit. It sends a message to the meibomian glands, the lacrimal glands, the goblet cells. These are all the glands that make a normal, good quality tear. So when we breathe every day, our normal breathing through our nose triggers that nerve. So 30% of our normal basal tear secretion is from just breathing through our nose, that we're constantly producing tears. So if you activate that nerve regularly, you can actually start producing good quality tears and normalize that tear film. So that's what Tyrvaya does. And this is one of the latest treatments that's been approved for dry eye disease. It's a nasal spray that triggers that nerve, sends a message to the lacrimal functional unit, and a tear is produced. It takes about 11 seconds between the spray and for you to feel moisture in your eye from the production of a good tear. It has side effects though. So it's a nasal spray. The main side effect is sneezing. So I tried it for myself. The first time I tried it, I sneezed 10 times right away within that first few seconds. The second time I used it, my sneezing got better. The third time it got less. And now I don't sneeze when I use it. But the studies that got it through FDA approval showed that if you use this twice a day, so you spray it each nostril twice a day, and you only need to spray down at the lower tip, doesn't need to go into the sinuses. And I tell patients, don't snort it, don't breathe it in. You just need to spray, and then wipe it off. But that twice a day use actually improves the quality of the tears, and it improves the volume of the good quality tears. So it normalizes that balance between the oils and the water layer and the mucus layer. So it's an exciting new treatment that is around. I don't know if anybody in the audience has tried it, but that's pretty cool. I'm going to stop and look at the chat and see what questions there are. So there's a question about how macular degeneration or wet macular degeneration affects dry eye disease, and it doesn't. Really, it's a completely different disease. Macular degeneration is a retinal disease way in the back of the eye. So it's very, very different from dry eye disease. The next question is, does blepharoplasty or ptosis surgery cause dry eye? So these are types of lid surgeries. And that's a great question, because sometimes when you have upper lid surgery and you take off some of the skin or you pull that upper lid up, most oculoplastic surgeons are very good and very respectful of the eyeball. So the care is to not take so much skin where your eyelids stay open at night. But initially, that could be a side effect of the surgery. And if your eyelids stay open at night, or they don't close well, or they don't blink well, you can imagine that it can make dry eye disease worse. The next question is, why do I recommend preservative-free artificial tears? Is there a major problem with the ones with preservatives? Great question. So preservatives, if a patient is using artificial tears more than 3 or 4 times a day, then you're getting too much preservative on the eye. So I don't mind preserved eye drops to carry along in your purse or if you're out and about. But if you're having to use the artificial tear more than 3 or 4 times a day, then I don't want that extra preservative on the ocular surface. It can cause further irritation. The next question is, which type of dry eye can be commonly seen among cataract surgery patients, and which eye drops are preferable to prescribe for them? So again, all forms of these dry eyes are seen with cataract patients. Cataract patients can have oil gland dysfunction, and often they do. So again, the drops are going to be based on the type of dry eye disease. So I'm kind of going through all of these. I start patients all on preservative-free artificial tears, but often we need to add on some other kind of prescription drop to help with inflammation if there is some. Any specific recommendations for dry eye disease patients with previous history of pterygium? So pterygium is a growth on the ocular surface that's usually from ultraviolet exposure throughout a patient's lifetime. And patients who have pterygia are often more inflamed. So they have a lot of tear film inflammation. If you've had surgery for pterygium and it's gone at this point, that's great. There may still be inflammation on the tear film. So sometimes we actually go on to use something like Restasis or Xiidra for patients who have active pterygium or history of pterygium. I have another comment. Tearvia, it worked to help my tears return. It took 6 weeks. It's pricey, but it worked. Yes, because it's new. So anything that's new often does not get covered well by insurance right away. So hopefully, as we have Tearvia available to us longer and we start using it more and more insurance companies and Medicare specifically will hopefully start picking it up. But you're absolutely right. It's very difficult to get it affordable right now, but it works really well. I agree. Is swelling below the eye associated with dry eye disease? Not always. Sometimes swelling below the eye is from not sleeping enough or from a salt imbalance. So it's not necessarily due to dry eyes. Do I have to take Tearvia forever? Nothing is forever. And patients ask me that about a lot of dry eye treatments. If you're feeling fabulous after a year on a certain treatment and you want to try to decrease it or come off of it, I think that's reasonable, but oftentimes the symptoms may return. So, some patients will come off and they'll get worse and then they'll go back on it. But I think it's reasonable to start a treatment and see if you do better. Sometimes you can wean yourself off. Tear via therapy is really exciting. Does it help in lipid deficient dry eyes? It helps in all forms because it triggers the meibomian glands as well as the lacrimal glands. Where's the list of tears that have lipids and no preservatives? Can you repeat the names of the steroids? So, yeah, I mean, we can chat more offline about this too. There's a long list of artificial tears, so I won't list those now. There's different steroids as well. There's a long list of steroids, Lotamax or Isuvis, Eyesuvis. Those are nice ones. Is Tyrvaya covered by insurance? Not all insurances, unfortunately. Does facial nerve damage post-acoustic, I assume that's going to say post-acoustic neuroma. Yeah, nerve damage to the eyes and face can often make the eyes less sensitive to pain, which is good and bad. You don't have as much pain, but also you can get dry eye without even knowing you have dry eye. So, you know, that's another form of dry eye that we treat. Is Restasis 4 times a day at the 0.05% safe to use indefinitely? Yes, it is safe. What do you think of tear care? I'm going to talk about that in a moment, so I'm going to skip that question. And I'll talk about compresses and all of that in a minute. So I'm going to close the chat. I'm going to continue with the lecture, and then we'll come back to questions in a little bit. One other treatment that I wanted to talk about, which I love and works really well for the more severe dry eye patients, is autologous serum, where I send the patients, we send the patient to get their blood drawn, and we spin down that blood, take the plasma portion and bottle it. And you use that on your eye like an artificial tear, but it's not an artificial tear, and it's got growth factors and vitamins. It almost mimics that good quality aqueous layer of the tear film. So I call it chicken soup for the ocular surface. It's got a lot of good stuff, and it really helps with the healing of the ocular surface. But it is a pain in the butt because you have to draw your blood. Usually with one blood draw, we can get about a 4 to 6 month supply for the patient. It's not covered by the insurance. And there's one national company that does this for us, and they charge about $600 for one batch. So there is an out-of-pocket cost that's not low. I mean, it's pretty significant, but it does work really, really well for patients who are more in the moderate to severe category. And it's very, very safe because it's your own blood on your eye. So it's very, very safe. So that's a treatment I use often as well. This is an amniotic membrane. It's called Procara. It's amniotic membrane. It actually is membranes from donated placentas from around the baby's sac. And that is freeze-processed tissue. It's cleaned and sterilized and all of that. And you can it's placed on almost like a contact lens ring. So this is for patients who have such severe surface breakdown. We actually put this on like a contact lens for about 3 to 5 to 7 days. And it helps heal certain types of ulcers on the surface or very, very severe breakdown of the epithelium from dry eye disease. It will blur the vision though, because it's opaque. So I can't put it in both eyes. I'll often put it in one eye. It's a little bulky, so sometimes patients will feel it a little bit. It's not too irritating, but this is something we use in the more severe patients. There is dry forms of it that can be placed under a standard contact lens. They don't work as well. I'm not a big fan. And there is something called Regenerize, which is that same amniotic membrane where they sort of extract the fluid. It's a sterile product. It's acellular, again, derived from placental tissues. And it's supposed to have some of those proteins and growth factors. It's not really FDA approved because it's not a drug. There's one company that makes it. And in my experience, the patients who use Regenerize, it works very similarly to autologous serum drops, but it's a little bit more expensive. They're both expensive out of pocket, but they work similarly because they sort of provide that nutrition to the ocular surface. Now, let's talk about lid margin disease, because I did mention this is like 85% of dry eye disease is related to the oil glands. So what do we have for that? Well, The most basic treatment you can do at home are hot compresses. Hot compresses are great. I tell patients it's like brushing your teeth at home. You do the hot compress. I have there's these masks you can buy and microwave for 20 seconds. They hold the heat for, because you need that sustained heat for about 5 to 10 minutes. The problem with it is my compliance with patients is low. I say it to almost every patient, and I see patients back and they say, oh, I forgot to do that, or it's too much of a hassle. I have to go down and use my microwave. I myself am not as compliant as I should be with it. That's the biggest problem with it. Otherwise, hot compresses actually work really well to melt those trapped oils. There are commercial lid soaps, lid wipes to clean the debris from the lid margin. This picture you see here on the side is called, let's see, I might have another picture of it here on the next page. Well, no, I don't. So let me go back to this one. So this is almost like a mechanical toothbrush. We call it Blef X. It's not a toothbrush. It's not bristled. It's a gentle tip, but it does, it's an automatic. It's done in the office. It's a procedure, and we use a special soap, and we really debride the base of those lashes where you can get a lot of that gunk, that hyperplasia bacterial lining that's building. So we're able to clean that off in the office. So it kind of gives you a boost in the right direction. And then I tell patients, do a lid cleansing at home regularly. This is just the anatomy of the eyelid. If you look at the eyelid, we have skin, we have muscle. The oil glands are on the back layer of that eyelid. It's that blue kind of fluffy stuff with the orange surrounding it. That's the meibomian gland. So when we put a hot compress on the surface, it has to go through multiple layers to get to those oil glands. And that's another issue with getting it hot enough. So there's procedures that we can do in the office to get to those glands. LipiFlow has been around the longest, and it's that picture on the lower left where we hook up the eyelids and we give sustained heat right over those oil glands for about 12 minutes, and it's accompanied with this pulsation and massage that deep cleans those oil glands out. So it's kind of like evacuating those trapped fats. These other procedures are similar. They're heat and squeeze. So we heat up those oils to melt those trapped fats, and then we squeeze out the glands. And they all work similarly. Here's me getting the LipiFlow procedure myself. It's 12 minutes. It's done in the office. None of these procedures are covered by the insurance, unfortunately. So they're all have a little bit of an out-of-pocket cost. Again, I tell patients, think of it as going to the dentist once a year and getting a deep clean. And then doing the hot compresses at home is like brushing your teeth. So it's maintaining the health of those oil glands, preventing them from becoming like toothpaste, like in that one video we saw. And this is sort of the business end of that LipiFlow. I won't go into the details here. What is IPL? Some of you may have heard of IPL. So intense pulse light. It was originally developed by dermatology for acne rosacea, for use on the skin in patients who have a lot of rosacea and these tiny little blood vessels that bring inflammation to the skin layer. Well, now we can do it for eyelids where, remember that picture I showed where the lid was very vascular, very red, very inflamed, and it basically coagulates those blood vessels that are bringing the inflammation to the tear film margin. So it works really well for patients who have what we call ocular rosacea. What about omega-3 fatty acid supplements, oral? They're wonderful. So these are fish oils. Not all fish oils are made the same. The best ones will be re-esterified fish oils. And if you take them at the recommended dosage, which I think is about 3 grams a day, they really work to normalize that oil layer of our meibomian glands. They're also anti-inflammatory, so they actually help dry eye disease quite a bit. Again, they should be re-esterified. There's only a few brands that are very, very good. I use myself PRN Omega Health. You can go online, look up PRN Omega Health. they make a very nice reesterified fish oil. Nordic Naturals makes another very nice reesterified fish oil. The Costco brand is not the same. It is not reesterified. So you need 10 times as much to absorb what you need. So the bioabsorption on these reesterified ones are much, much better. Okay, this is a gross picture, but these Demodex mites are real and most of us have them. And we are realizing this more and more, that it's really ubiquitous. These are tiny little mites that burrow into our eyelash margin and they reproduce there. We think that everybody has a little bit of these. It's the only problem is when they overgrow. And a lot of patients will have a severe overgrowth of these mites at the base of their lashes. And it gives them blepharitis. It gives them eyelid itching. It gives them eyelid inflammation. It clogs the oil glands. They're just terrible little critters. And if you see in this top picture, when the patient looks down, you can see that almost like a greasy sleeve around the base of that eyelash. That's the nest. That's where they bury in and reproduce. So horrible little guys. What do we do for them? Well, nothing great yet, but there's very good hope in the upcoming future. Right now, we do know the active ingredient of tea tree oil can suffocate the mites, but you can't put direct tea tree oil on your eyes. It burns too much and it's not safe. There is a brand of eyelid wipes called Clearadex that has the active ingredient in there. So you have to cleanse the lids at the base of the lashes twice a day with that to kind of keep the burden low. The good news, which I'm really looking forward to, is that there is a product in front of the FDA right now. It's expected to be approved in the next few months, and it will hopefully be in our hands in about 6 to 9 months, hopefully. It's an eye drop. It's an eye drop that you use twice a day for 6 weeks, and it goes in and it kills the mites, and it's 100% safe to the mammalian cells. So it kills mite cells, the nervous system of the mite, but it's safe for human cells. And it completely wipes them out. Now, they can regrow again, but it takes 6 months to a year for them to regrow again. And then you can use the therapy for another 6 weeks. And so this is going to be a real big game changer for patients who have chronic, what we call blepharitis, lid margin disease, oil gland dysfunction. So we're really looking forward to getting this available for us. All right. There's something called meibomian gland probing, not done very commonly. We're not sure if this is really a therapy that's going to take off in the future, but there's a few doctors who will actually go in and poke through those oil glands to try to get them to reopen a little bit if they're clogged up. There's some good evidence that it does help in certain patients. And finally, scleral lenses. These are giant contact lenses that sit over the cornea, and there's always a bath of fluid between the contact lens and the eye and the cornea. And so the cornea is constantly bathed in a fluid. So again, for very, very severe dry eye patients where no other therapies work, scleral contact lenses are an option. Some patients have a lot of extra, what we call conjunctiva. The mucous membrane on their surface is just excessive. And so it droops out of the eye. You see that in that lower picture here. And if you pull it, you can see how much extra tissue there is. That can cause really significant burning because the tissue kind of pokes out of the lower lid. And so sometimes we'll actually go in and trim it. It's a very simple procedure that we do, and it can often make dry eye feel much better for patients who suffer from this particular disorder. Lots of emerging therapies as well. I'm not going to go into all of the details, but there's dry eye disease is a huge industry, and the ophthalmic pharmaceutical industry is aware that there's a huge gap and so many patients who are undertreated or not well treated. So lots of different therapeutics coming to the market over the next few years, which will offer more options for patients. No two dry eye patients are the same. So I have a lot of patients that come in and say, well, this worked for my friend, but it doesn't work for me. because everybody's eyes are completely different and people respond differently to different treatments. There's no quick fix. It usually it involves multiple interventions. I have patients come and go multiple times to, again, figure out the cocktail of treatments that will have the best effect for patients. And the goal is, it's not a curative thing, but it's to have you have more good days than bad days. I tell my dry patients, if you're not thinking about your dry eyes every day, then we've made some progress. So don't get frustrated. I suffered from dry eye disease. Many of my colleagues do, because we're on the screen all the time. It's much more common in younger patients now because of increased screen time. And so we're dealing with it all the time as eye care professionals. And there's hope and lots of things on the horizon. So with that wraps up my slides. I'm going to jump into question and answer now. And I think we have a few more up here. So there's a question, what do I think of tear care? Tear care is one of those heat and squeeze procedures. I do tear care for a lot of my patients, and I think it works really well. It's a little bit more aggressive than LipiFlow because we have to kind of squeeze those oil glands. It's a little more uncomfortable, but it works really well to evacuate those trapped oils. How often can I use warm compresses at home? I usually say if you can do it twice a day, that's great. If you can do it once a day, I'll take it. Even if you do it 3 or 4 times a week, it's better than nothing. So do it. It's good for everybody. I have a patient that who wears scleral lenses, who's had acoustic neuroma surgery. Is Tyrvaya an option for improving dry eye caused by facial nerve damage? I think so. So Tyrvaya has shown a lot of promise. A lot of patients that were not helped by anything else. Tyrvaya, which is that nasal spray, has worked really well. So I would say, let's try it, and why not? How and where can I find the wet compress mask? There's a mask called Bruder mask, Bruder. You can find it on Amazon. That's a really nice one. That's the one you can microwave. There is also some masks that you can plug in with a USB port. That it's dry heat though, and those work well also on Amazon. They can be found. Can you comment on the recent recall of eye drops? Yeah, this is an eye drop that I've never used. So when I saw this article on contaminated eye drops, I had never even heard of this eye drop. So it's a very weird one. I don't know where it was manufactured, but the ones that are at your local pharmacies, for the most part, they've been vetted. The ones I have on my list, these are all been vetted. I've never seen an infection happen from preservative-free drops with the brands that we use. If eyes are normal, should we use compression and lid scrub regularly to maintain eye health? That's a great question. I think especially for women, one thing I recommend, whether you have dry eyes or not, is make sure you take off the makeup at night, and doing a lid wash even a few times a week, I think is good for the general health, keeping those oil glands open and flowing and moving. Could I repeat the name of the recommended omega-3 pills? So I like PRN Omega Health. I'll put it in the chat here. PRN Omega Health works. That's a really nice one. But there's also Nordic Natural, I believe it's called. Do I think using screens for long time causing shortage of breathing? Using screens for a long can cause shortage of breathing and cause dry. Well, using screen time causes dry eyes for sure. Our blink rate goes from 16 to 20 blinks per minute, which is normal, down to about 4 per minute when we're in front of a screen. So our blink is really important because that physiologic blink is what causes those oil glands to release their oils and to spread that oil across the tear film. So when we're not blinking, those oil glands are not getting massaged, and so they're getting trapped and they're turning into fats. So blinking is very, very important to our eye health. Can I share the list of eye drops that I recommend? So I'll put a few that I like in the chat. But there are more than these. But those are sort of my top 3 choices. There's another really good one that has recently come on the market called Ivisia. It comes in a preservative-free bottle. That's also a very nice one. What is the cost of tear care and similar methods? So I can tell you what UCI charges. They charge about, for LipiFlow, $1,000 for both eyes. So total. Tear care is about the same. I think it's $1,035 or something. And they run about that. Some community doctors may charge a little more or a little less, but that's what they usually run. Dose of PRN Omega Health, I believe it's 3 grams per day, but it's written on the bottle when you order it. Restasis, question mark. Yeah, Restasis is good. We use Restasis. It's the first one that was out there for dry eye disease, and it works for some patients really well. It's expensive. Yeah, Restasis just went generic, but interestingly enough, the generic is sometimes more expensive than the brand. So I don't know what's happening with that, but usually I try to figure out what gets covered the best. I'm not a big fan of the generic in general. So I often will switch patients to Xiidra because Xiidra seems to get better coverage, especially with Medicare. Wonderful. All right. Well, it's been a pleasure being here with you guys tonight. Where can we purchase omega-3s? So if you go to PRN Omega Health that I put in the chat, it's actually online, so you can order that online.
Does anybody have a question they'd like to ask without the chat, just by asking Dr. Farid? If all the questions have been answered, we will thank Dr. Farid for another excellent lecture, and hope that you will take away some great information from this. We will be sending out the video recording in the coming weeks. The next lecture coming up is AMD with Dr. Stephanie Liu and Dr. Mehta, and that's on March 7th. Thanks so much for joining us this evening, and we look forward to seeing you again soon.